Hi, everyone. It's so good to be here, and I am really happy and fortunate that I can present um, a little introduction for my colleague, Dr. Cate Fortier. We work together at the VA Boston healthcare system, which you've heard me talk about a little bit before. Dr. Fortier is also an assistant professor at Harvard University. And she's got a very impressive research background, and she's an active clinical neuropsychologist as well. She's had funding from NIH and VA. We'll hear a little bit about one of those projects today. And over the last year and a half, maybe two, Cate, I've had the pleasure of collaborating with you on projects related to intimate partner violence, traumatic brain injury, subconcussive injury, and post-traumatic stress disorder in particular. And so it is my pleasure to introduce you. We haven't had a lot of speakers talk to us about different treatment options. And I think I speak for all of us when I say we're really excited to hear about your application. Let's take it away.
Thank you. Thanks so much, Cate. I will start sharing my slides now. And we were commenting earlier, it was very nice to hear about the studies going on at Mount Sinai. The intervention that I'm going to be talking about today is based on an evidence-based intervention developed at Mount Sinai in conjunction with Dr. Kristen Dams-O'Connor, Short-Term Executive Plus. And this is an intervention or a workshop that was originally developed for civilian traumatic brain injury, but we have adapted at VA Boston to treat post 9/11 veterans with traumatic brain injury. And importantly, not just TBI. TBI actually isn't even a requirement to be in our research study or to participate in our workshop, but to treat TBI and the multiple clinical comorbidities that come along with it. So other health, both neurobehavioral, psychiatric, and other behavioral health conditions that frequently accompany traumatic brain injury. So that's really what I'm going to talk about today. And I feel free to let me know how it's going and how our time frame looks. And if you'd like me to move along a little faster, my plan was to go over some of our TRACTS National Center for TBI data that speaks to the level of frequent clinical comorbidities seen in post 9/11 veterans. So I plan to start there and to tell you a little bit about why this particular group of veterans have multiple co-occurring diagnoses that happen frequently together, and why we think that focusing on single symptoms or single diagnoses is not really the way to go with this group of veterans. And then I'll tell you a little bit about the intervention itself, which is called StepHome. It's a novel group skills-based transdiagnostic, so any diagnosis or even no diagnosis required to be part of the workshop or cognitive behavioral skills group. And some of the data that shows that StepHome has been able to improve treatment engagement, therapy compliance, reintegration status for veterans, so adjustment back to the civilian world, and cognitive and emotional function as well. And then kind of float the idea to you all to see what you think about whether this would be an applicable intervention for survivors of intimate partner violence, including some data from TRACTS that hopefully may convince you that it could be. So these slides about our data from the TRACTS National TBI Network Center, I will go through rather quickly, hopefully just to form the basis for some of the slides to follow. But if anyone has any questions, again, please interrupt and let me know. I think also most of you are probably familiar with a lot of this data, so it's not surprising to hear that mild traumatic brain injury is the most common form of injury sustained by veterans who serve in Iraq and Afghanistan. You can see that of all traumatic brain injuries, over 80% of them are mild in severity. And what makes traumatic brain injury particularly unique in veterans who served in Iraq and Afghanistan is the way in which most of the traumatic brain injuries occur. So most of them are combat-related injuries. About 75% of all military TBIs from post 9/11 veterans are caused by blast explosions. So the argument is that blasts not only produce physical injury, but also produce psychological injury at the same time or simultaneously. And we at TRACTS think it's really important that it's this physical and psychological trauma that co-occurs that really sets the stage for complex physical and psychological illness after service in the military. And as you can probably imagine, that is part of why I think this intervention may be particularly applicable to female and male survivors of intimate partner violence, because they have that in common. So TRACTS is a national TBI Research Center. We've been funded since 2009. We have 2 sites, one in Boston and one in Houston, Texas, at the Michael DeBakey VA Medical Center down in Houston. TRACTS supports a very longitudinal, large, detailed data set that I'll tell you a little bit about. You can see these are the number of veterans that we have enrolled to date. So in Boston, we've seen over 650 veterans for a baseline visit. And then we see the veterans back every 1 to 2 years, 1 to 2 years after the baseline visit. And thereafter, we're following them every 5 years. So similar to what you heard in some of the other research studies, we are very interested in how TBI affects your health status as you age. So this is a longitudinal based study to look at the effects of blast injury, other traumatic brain injuries, and post-traumatic stress disorder and other health factors that go along with TBI in this group of veterans over time as they age. In Houston, we've seen almost 200 veterans, and we're starting our longitudinal follow-up for them as well. That site was funded in 2015. So our sample is about 860 so far, and these little dots you see down here at the bottom are all the zip codes of folks that have come to Boston for our research study. So lots of people do fly and come a long way to be a part of the research.
Cate, I think Ramesh had a question. Ramesh, did you have a question?
Yes, sorry, thank you. Kate, quick question. So with the cohort of veterans that you have identified, do you also know, are you separating them by how many episodes of blast they have been exposed to? And are all the episodes, documented? Because we've heard different things with respect to, whether they, they kind of try to hide it and things like that. So
yeah, that's a wonderful question. So I'll show you after this slide, I'll show you one slide on some of our TBI data in the sample. But yes, we use the Boston assessment of TBI lifetime, which we call the battle, to assess for traumatic brain injury and blast exposure in this group of veterans. So we assess blast exposure regardless of whether you experience a traumatic brain injury at the time. We usually have to use distance as a proxy for size of the blast because we don't have enough information from their retrospective account usually for that. But we do have blast exposure data on every participant within 100 meters and then as close as 10 meters, because we've actually have a large literature of data showing that being as close as 10 meters to a blast has long-term functional outcomes for both brain and behavior. So we get that data, and then we also assess whether the events meet criteria for a mild or more severe traumatic brain injury at the time of the injury. And one thing that's really different about TRACTS is that we are a very holistic minded research center. So when the VA first funded us to study traumatic brain injury, they actually asked us only to study TBI, but we realized that we would be missing a huge part of the picture in this group of veterans if we didn't look at other factors regarding their health status as well as post-traumatic stress disorder. So this here is the assessment for each TRACTS veteran. So every veteran that comes to our center goes through this full assessment. It takes about 10 to 12 hours for them to make it through all of this, as you might imagine. So we get these 5 classes of data on everyone, including blood chemistry, genetic information, cognitive data, psychiatric data, the TBI data that I was mentioning, including blast exposure and imaging data as well. Both structural and functional imaging is how they end their day. In terms of our ability to track TBI and blast exposure related to Department of Defense records. We actually have a paper under submission right now comparing the battle TBI retrospective clinical interview diagnosis of TBI to Department of Defense records that have become available through the electronic medical record system at the VA. And although we don't show tremendous agreement between the clinical interview and the records, we do show moderate agreement for occurrence of TBI. And what we believe is driving the lack of higher correlation between the interview and the records is that about half of the veterans, 50 to 60% of the veterans that we identified do not have any record whatsoever of any blast or TBI injury in their Department of Defense record. So basically they didn't report it at the time of the injury for whatever reason that might be. So when they do report, we show relatively good agreement between the retrospective interview and the medical records. But what we see is that the Department of Defense records really do not capture the wide variety of injuries that are occurring, as I think most everyone is already aware of. Not really a surprise there. And this is the TBI data from almost 500 in our sample. So as you can see, they have mild injuries predominantly, but there are a few moderate and severe injuries, but almost all mild. And the veterans who are in our sample have TBIs that occur across all of these contexts. So they have TBIs that occur during their deployment, secondary to a blast exposure or blast munitions. But they also have blunt injuries, usually related to combatives, air jumps, motor vehicle accidents, falls. And they have a very high rate of traumatic brain injury, mostly mild or almost all mild, occurring prior to their military service, and some occurring after their military service. So they have injuries that span the lifetime. And that's why we think it's so important to assess for the whole lifespan and not just combat related TBI.
Are the mechanisms for injury broken down in the pre-deployment? Would that be like football players?
Mm-hmm. Yeah, we know the etiology of each injury, actually, because of the Boston assessment for TBI lifetime. There's a lot of sports injuries, a lot of falls, a lot of football, a lot of martial arts, a lot of childhood related playground type accidents, different stories due sometimes to the higher risk-taking behavior of this population, but just to every day-to-day life as well. So this is the most important slide I wanted to share with you regarding our TRACTS data to make the argument about the kind of interventions that fit this cohort of veterans. What I'd first like you to see is that very few, only 8% of our sample, have a mild traumatic brain injury with nothing else, so no other co-occurring clinical condition. So mild traumatic brain injury on its own is very rare in post 9/11 veterans. But I think veterans in general. And what you're looking at in the red and the gray is that when folks have a mild TBI, so they have some history of mild traumatic brain injury, you see in red, there's a significantly greater chance of having a greater number of co-occurring conditions than when they have no TBI, which is in gray. So the very first line you see is the 3+ comorbidities. So when you have a TBI, more than 70% of folks with TBI have 3 or more other co-occurring conditions that are listed down here below the TBI. Whereas when you don't have a TBI, your chances of having 3 or more conditions is about 40%. So something about having a mild traumatic brain injury sets you up for greater occurrence of other mental health and neurobehavioral disorders like sleep disturbance, pain, depressive disorders, major depression, as well as other depressive disorders, and post-traumatic stress disorder. So what we think is that it really is that synergy of the psychological trauma and the physical trauma co-occurring that leads to this increased number of clinical comorbidities when you have a TBI. So that in and of itself is interesting. But what really matters is how that affects your functional outcome after you have a TBI. So I'm going to show you just a few slides. This slide shows how the clinical diagnoses group together using a factor analysis in the TRACTS sample. But again, what I'd like to focus on is how having multiple interacting clinical diagnoses impacts your long-term functional outcome. So when we did a factor analysis of the TRACTS data set, this is how our behavioral and psychiatric diagnoses statistically clustered together. And the factor that you're seeing here under factor 1 that we called the deployment trauma phenotype is made up by mild traumatic brain injury, mood disorder, and post-traumatic stress disorder co-occurring together in one individual. So we have multiple papers that have come out of TRACTS now over our first decade that show that when mild traumatic brain injury occurs in the context of other commonly occurring diagnoses, but most in particular, when mild traumatic brain injury and PTSD co-occur, that a lot of different outcomes, brain, behavior, cognitive, are worse in the long run. So I won't go into any details of these studies, but I'll just give you a flavor, like a couple of examples from TRACTS that show that when you have multiple diagnoses, and this paper in particular is the deployment trauma phenotype I mentioned. So when you have depression, mild traumatic brain injury, and PTSD co-occurring, then your functional abilities to handle day-to-day life activities is worse. So basically, the outcome here is the World Health Disability Scale. And what we showed is that when veterans have these 3 co-occurring disorders, they are far more likely to be disabled and have more severe levels of disability than any other 3 combinations of diagnoses. So it's not just a factor of burden, it's that there's something particular about mild traumatic brain injury when it co-occurs with depression and PTSD that makes outcomes worse. And we have another follow-up study that we did, an actual epidemiological study, because that study I just mentioned is in the TRACTS sample. So it's in a convenient sample of post 9/11 veterans. We were able to replicate that finding using employment status as an outcome variable in almost 50,000 veterans using the VA medical record system. So we looked at the same 3 diagnoses, the deployment trauma phenotype, and we found strikingly the exact same prevalence in the medical record. It was about 16% of post 9/11 veterans have those 3 diagnoses. But those 3 diagnoses account for over 70% of disability seen in this sample. I'll show you one more slide about this one. So we were able to extend these findings using employment as an outcome. And this is a fairly complex slide, but again, it's from 48,821 veterans who have medical records that document these different disorders, and looking at employment as the primary outcome. And what you see with the solid line is the rate of unemployment for non-disabled veterans. So that's 7.7%. And then what you see with the dotted line is 13.8%. So that's the unemployment rate among those in our sample who do not have mild traumatic brain injury, PTSD, or depression. Because we wanted to make sure to account for the time and the relative economic downturn that we're showing, because this is from 2009 to 2013. So what I want to point out are the 2 circles, though. As you can see in the first circle that shows mild traumatic brain injury only here on the graph, those with mild traumatic brain injury only and no other diagnosis have the lowest rate of unemployment. Exactly why that is, we don't know. Among veterans, they could be a particularly resilient group. And then at the other end of the graph, what you see with these 2 bars here, about 20%, is PTSD and depression together, and PTSD, depression, and mild traumatic brain injury, all three co-occurring, have by far the highest rates of unemployment, with almost 20% of people having left the workforce altogether.
Kate, do you know what the male to female breakdown is in this group?
In this group, I actually, I can let you know, in the TRACTS sample, it's about 10% of the sample is women, which is pretty representative of the veteran population. I believe it's very similar for this epidemiological sample. I can go back one slide.
My guess would be that the women would have an even lower unemployment rate from the
Yes.
work of Odette Harris and Maheen.
I agree. Yeah. And I actually won't tell you too much about gender differences in the track sample. That's something that we've looked at as well, and I think definitely supports what you're thinking.
We have another call on Thursdays. I'm going to get you on for that one, but I'll let you continue.
Okay. So all of this data together that I've shared with you from our TRACTS TBI sample really shows that mild traumatic brain injury on its own, when it does not occur with other psychological or physical injury, and I'm only talking about mild traumatic brain injury, not more severe brain injuries, generally does not produce lasting or significant cognitive or functional impairment in post 9/11 veterans. But when it coexists with other conditions, which it usually does, we hardly ever see it on its own, it really does something that contributes to much more devastating long-term outcomes, negative outcomes, both to function and to brain structure, as well as cognitive abilities. So we really think that post 9/11 veterans are characterized by what we call like multi or polymorbidity. So they usually have multiple co-occurring diagnoses. And that are these diagnoses are often common and overlapping. And while each one might have a negative effect, it's really all of them together and that cumulative burden that causes problems with daily living. So this is why we developed StepHome, the workshop that is based on Mount Sinai's civilian TBI program to treat traumatic brain injury as well as co-occurring mental health disorders in post 9/11 veterans, because they have multiple co-occurring conditions, not just one. So we really feel like it's time to think differently about the best way to treat multi or polymorbid groups. We hear lots of other research groups talking about the different, these different things I have listed here on this slide about treating them in isolation, or treating one diagnosis at a time or one problem at a time. And at TRACTS, we've just seen that fail time and time again, and think that these veterans really need a more integrative, holistic approach. So, Western medicine and current medical practice typically does take a silo approach or does treat one thing in succession and move on to the other. Although obviously there's lots of exceptions to that, including VA's whole health initiative right now. But we think in general, treatment needs to move more in the direction of being holistic, treating the person and treating multiple disorders in one platform instead of one at a time. And even if it might not, even if you can move veterans into further treatment, say for post-traumatic stress disorder or other single diagnoses down the road, it's an important first step to engage them and give them a positive experience before trying to move on to, for example, trauma-focused work. I guess I'd like to just let you know, in terms of the veterans that we see for our StepHome workshop, give you a flavor of what that looks like clinically for the type of patients that we do see. So most of the veterans that we work with in our workshop have been diagnosed with PTSD from combat, but they often have PTSD from life experiences prior to combat. They might have early childhood trauma exposures and early childhood PTSD. Most have at least one mild traumatic brain injury from combat. Many might have a TBI from some other source prior to military service or have both. A lot of them have different mood disorders or anxiety disorders on top of PTSD. Many of them struggle with substances. So even if they don't have diagnosed alcohol or substance use disorders, they tend to report struggling with difficulty controlling their use of these substances in civilian contexts. A lot of them have chronic pain and some have opiate dependence. Most are from lower socioeconomic backgrounds and have limited financial means. A lot of them aren't working. A lot of them, if they are working, are bored or don't feel fulfilled by the job that they're doing after their military service. Many got jobs right when they came home, but then reported that things fell apart later. So they might have been doing well for the first year or two, but then things fell apart. And they almost all struggle with irritability, anger, attention and memory and concentration problems, isolation, feeling like they're no longer part of a team, and just getting things accomplished in day-to-day life. So for all of these reasons, and as well as the fact that the fact that many post 9/11 veterans are often resistant to mental health treatment. Maybe it is seen as a weakness to need help, to need psychotherapy or mental health treatment help. They tend to no-show for appointments and you have trouble with the VA getting them scheduled and getting them to show. As I mentioned, post 9/11 veterans may just not be ready for intensive trauma-related work. Um, and then, basically most of these veterans are struggling with that transition from a very structured military context to a very unstructured civilian world. So for all of those reasons, we feel that an integrative option is needed. To further back this up, there's also not many integrative options available within VA. So the type of program that Mount Sinai offers for cognitive rehabilitation tends to be a gap that we see at the VA. There also is not much vocational mental health combined services. So our workshop takes a vocational or a community-based approach. So that's something that sets it apart as well. And, although gold standard treatments for PTSD are the best thing available to treat PTSD, you have to get people engaged in intervention to help them. And a lot of the post 9/11 veterans we work with just aren't ready yet for trauma-focused therapy. We tried to populate a cognitive processing trial at TRACTS from 2009 to 2012. We spent 3 years trying to get folks to sign up, and we could not get any of the younger veterans to sign up, whether that's avoidance and part of their PTSD or not being home long enough to see the havoc that trauma can lead in their life over the years. Our goal is to get them there, but we think they need to be engaged and give them a positive experience in order to move towards more trauma-focused interventions. Again, so this is just reiterating most of the things I've already said, but there really is a need within the VA for a more integrative, problem focused in terms of day-to-day problems, transdiagnostic approach to the treatment of this group of veterans, given how many different co-occurring conditions they struggle with on a daily basis. So for all those reasons, we developed StepHome, and it is based on Mount Sinai's program, Short-Term Executive Plus. We have adapted that program very specifically for post 9/11 veterans. Our goal is to help veterans reintegrate or transition from military to civilian culture. It's very much a skills training approach. So we don't call it therapy, we call it a workshop, trying to reduce some stigma around mental health treatment. It's a group. We meet for 90 minutes a week for 12 weeks. And most importantly, it's transdiagnostic. So it's open to any veteran who is struggling with any of those issues I mentioned: memory, concentration, anger, irritability. So if you're struggling with day-to-day life, you are eligible for this workshop. As it works out, as I mentioned, most of them have mild traumatic brain injury and have other co-occurring mental health disorders. And that is why they're struggling, but we don't require that to enter the workshop.
How many veterans can you help at one time that are?
So we have moved our groups online during COVID, and we try to keep them a little bit smaller in online groups just because it can be challenging to all participate. We actually think online groups need to be a bit smaller than in-person groups based on what we've learned so far. So in person, we would generally have up to 8 veterans in each group, but it ranged from 4 to 8. And with online groups, we shoot for about 4 veterans, but 4 to 6. So, and we're constantly running and enrolling new groups. Right now we have 4 groups running. So.
And are those run, is there a peer support model where there's a peer that's part of that, or is it run by social workers, or what is the
Yeah, so we're actually in the randomized control trial phase of StepHome testing its efficacy. So I have some data that I can show you that it has proven to be feasible and acceptable for post 9/11 veterans and shows some good pre-post changes. But right now we're testing the efficacy. So during that time, we're rolling it out with master's level or above. We usually have 2 co-leaders. My colleague Alex Kenna is actually here, and she runs the group. So I think she joined us for the call today. She has a PhD in counseling psychology, but we have other people who, so she'll run the group with a co-leader, but we also have master's level folks who run the group with a co-leader. So basically 1 master's level person with group therapy experience, and then anyone with a bachelor's or above, or any kind of degree. We have some social workers who we've trained to run our groups. So the criteria that we've outlined for the randomized controlled trial is master's or above. But I think that anyone could learn to do this. So anyone with some cognitive behavioral skills background and some group therapy background. So
Hey, we had a question that was relevant right before you move on, if you don't mind.
Sure.
Jessica Huckabee was wondering if this research or the groups you're running are open to service members.
Yep. Yeah, so we hear that a lot. We have had a lot of interest from active duty service members and folks who are still in, mostly National Guard, I'd say. But we do treat all branches. It is open to active duty as well as veterans. And one thing that's nice is that because we are a research study, nothing has to be entered into VA medical records. So for active duty service members in particular, that's usually very important to them not to have anything documented in the medical record while they're still active. So they don't need to worry about that because it is a research-based intervention at this point still. We obviously hope it'll be rolled out across VA at some point, but we're not quite there yet.
And I actually,
yeah.
sorry. I was gonna say, I actually had a question too when you're
Sure.
talking about predictors for later long-term problems. And you said that it's not just brain injury alone, but the confluence of brain injury, PTSD, and depression, or one or the other.
Mm-hmm.
Is that irrespective of whether it was one or repetitive brain injuries? So if you had, say, 7 or 10 brain injuries, you won't see an effect. I just find that hard to believe.
Yeah, so we do not have any TBI dose effects that we've been able to document yet in the TRACTS sample. We have looked for them. In general, mild traumatic brain injury on its own in the TRACTS sample has just not been the strongest indicator of brain structure, resting state functional, or other outcomes. We actually have seen, to your point though, we've seen greater effects related to being in the proximity of a close blast than we have with mild traumatic brain injury itself.
Mm-hmm.
So, we feel like there's something about being close to blast munitions, whether it is the effect on brain or the co-occurring effect of the brain on the brain and the psychological trauma at the same time. I mean, that's what we're trying to tease apart on a daily basis with the work we're doing. But we don't have any we've never been able to show a dose effect with numbers of TBIs yet. Subconcussive repetitive blows to the head are something that we started gathering additional data on around 2015. So we don't have it on that full cohort, but that's something that I think that you really will see a dose effect there, for sure. And we are actively collecting that data.
Yeah, I think, not anecdotally, but, anecdotally and, from the evidence that we have, one brain injury in itself, mild, certainly overall, you're going to say, yeah, you have a pretty chance that nothing's going to be bad in the end. It may be 2 weeks, 3 months, 6 months. But overall, that one is, pretty low likelihood you're going to have. But once you get up to, in 2 maybe, but once you get up to 3 or 4, I think that's where we are much more confident that, the likelihood of you having something going on later on is, we can say now you might want to worry. So I was just wondering.
Yeah, and I think
if
also if they're close in proximity to each other, outcome is probably even worse.
Yep. Yeah, so that's, it's just, I don't know how many people you have that had just like one brain injury versus.
No, there's a lot of multiple injuries in the sample,
Yeah.
and we do see
Yeah. That's
that there's
interesting.
effect related to the close blast exposure, but we
Okay.
haven't yet seen it related to concussion.
That's interesting because
Yeah,
I would
it
have expected repetitive concussions to show something.
Yeah.
So yeah, that is interesting.
Yeah, and I mean, to be honest, also PTSD is it eats up all the signal. So the effects of PTSD in our sample are so strong that it's hard to get an additional signal of mild traumatic brain injury on top of that. So that's something, that we're always looking at as well.
Oh yeah. Yeah. I just didn't know if you had, I guess you have.
Mild
you probably have
traumatic brain injury, as I mentioned, by itself in the sample is 8%. So
yeah, so you have very little.
very,
Exactly.
very little.
So it's
concussion.
okay. That makes a lot more sense.
Yeah.
Okay.
Yep. So we're looking at all of these things in combination, and that's why we think we need to treat them in combination too.
Yeah, absolutely. Thank you.
Yeah. So I know we don't have too much time, so I will let you know that we have a lot of work documenting what the workshop is about, but the core of it is to really teach problem solving, emotional regulation, and attention training across domains that are relevant to post 9/11 veterans. So we use common military to civilian cultural differences and expectations about the different cultures, and we talk about community and family and jobs, and provide a lot of psychoeducation about what symptoms are related to PTSD, what are related to TBI, what are shared. We've spent a lot of time on anger management, and usually build the problem solving and emotional regulation skills through these different content areas that are relevant to our veterans. And before I stop, I have a bunch of data on the fact that veterans like our workshop. They attend, they drop out at much lower rates than trauma-focused work, which isn't surprising because it's harder to do that work. But veterans generally like it, and they show some improvements on how connected they feel to VA services in particular, as well as the attention, problem solving, and emotional regulation skills we're trying to teach them. And they also show some better adjustment from military to civilian reintegration, or just community connection, community reintegration. So they feel better connected to civilian community and better connected to VA services after they finish the workshop. But the other most important thing about StepHome is that what we're trying to do is get them in the door and give them a positive experience and get them connected with additional treatment. So what StepHome offers is a first experience with psychotherapy and mental health treatment that leads to further engagement in additional critically needed treatments, as I mentioned, trauma or depression or anything, substance abuse treatment, anything. But it gives veterans a positive first step, a positive opinion about what mental health care can offer them in their lives. And we work very, very hard on getting them engaged with additional treatment as needed after. Now, I know I don't really have much time left, but I had planned on telling you about IPV rates in the TRACTS sample and trying to make the argument that this intervention is a good one for them.
Kate, I just decided to go rogue, and we're just going to keep going because it's our show. So
Okay.
if you have to pop off at 3 o'clock, we're just going to keep going because this is so fascinating. And we'll have the recording. So if you have to leave at 3, please do, and then we'll keep recording, and I'll send out the recording so you can watch the last 10 or 15 minutes that you missed, because I just don't want you to stop talking.
Thank you so much.
That's if you can go over, Cate.
Yeah, no, that's fine. And I don't want to take up too much of everyone's time. And I know that a big goal of our group is to discuss this. So I want to open the door for discussing whether everyone thinks that it would be applicable to intimate partner violence. And I'll just show a couple more slides to try to make that argument, and then hopefully we could talk about that. So again, everyone on this call probably is well aware of the incidence and the importance of studying intimate partner violence, and the fact that injuries to the head, neck, and face are frequent, and concussion, therefore, is a very strong risk factor. But IPV does also increase risk for other mental health problems, such as post-traumatic stress disorder, depression, suicidality, and substance abuse, similar to what we see in the veteran. It's not identical, but similar. So I would try to make the argument that they are in need of more integrative services as well. In particular, what we see in that TRACTS sample that I've talked to you a little bit about today, this is data from both sites. So the Boston and Houston sites, the first 812 consecutively enrolled women and men, that's 731 men and 81 women. Of that sample, almost 40% of the female veterans and 20% or 22% of the male veterans reported one or more history of lifetime intimate partner violence. And both men and women, so across gender, those with IPV and a history of at least one or more episode of IPV prior to their assessment at TRACTS, end up with greater incidence and severity of post-traumatic stress disorder when we see them. So you can see this is all the different time periods we assess for trauma. So at the time of their evaluation, if you have a history of IPV, 64% of folks meet diagnosis for current PTSD, whereas 53% with no history of IPV have current PTSD. And these kinds of relationships in terms of history of IPV being associated with greater severity score in terms of the CAPS, as well as greater incidence of PTSD hold for prior to military service, after military service, as well as the time at which we see them. So across the lifespan, folks who have a history of IPV have more severe and higher incidence of post-traumatic stress disorder. So no surprise, but it's bearing out in our sample as well. And then veterans who have that positive history of IPV are more likely to meet diagnostic criteria for other clinical disorders. So if you have a positive history of IPV, you are significantly more likely to have a current mood disorder, a past or lifetime mood disorder, a current anxiety disorder, a current substance use disorder, which is alcohol and substances, a past substance use disorder, sleep disturbance, and pain that's of a significant level that it interferes with your daily function. So it's like greater than a 4 out of 10.
And Cate, just that 188 is a combination of male
Men and
female,
women.
right?
So I do have all these slides broken out by gender as
I know.
well, but I won't.
My brain just works that way. I'm sorry.
I know. I thought about doing it both ways, but in terms of both genders, if they both could benefit, TBI was also higher among those with the history of IPV in this veteran sample. So even in a veteran sample who's also at great risk of TBI, mild TBI, having a history of IPV increases the lifetime TBI diagnostic rate in the veteran sample as well. And this is what I think is probably most important, and what I tried to argue with TRACTS, and now I'm trying to make the same argument related to intimate partner violence, is that day-to-day life and interference with daily functioning problems with daily functioning is elevated when you have a history of intimate partner violence. So the World Health Disability Scale is the first column here. And all of these are significantly higher when you have, or significantly more impairment when you have a history of IPV than no history of IPV. Neurobehavioral symptoms, so post-concussive and neurobehavioral symptoms, and then psychosocial functioning are all significantly affected by having a positive history of intimate partner violence in this highly comorbid veteran sample. So similar to what I presented in terms of veterans, I think that treating traumatic brain injury in intimate partner violence may lend itself to a more integrative approach like we are trying to take with our post 9/11 veterans, because IPV has the same critical factor that usually when a concussion occurs related to intimate partner violence, it occurs in a very highly emotionally charged traumatic situation. And there is something different that happens with TBI when it occurs in that context that leads to worse outcome in our veterans. And we believe that that very may well be true for IPV as well. So whereas a TBI may have a negative effect on its own, it's really when it co-occurs with other psychological and health-related conditions that outcomes are far, far worse. And the StepHome Workshop teaches skills that are applicable across any diagnosis, skills that would help each and any one of us kind of manage our day and deal with frustration, irritability, memory lapses, attentional lapses more easily. So the skills that are taught in the workshop are transferable across diagnosis. And it's generally easier to get people to sign up for these boot camp type workshops instead of therapy. And we really feel that StepHome and the kinds of skills that we're teaching them are transferable to any multi or polymorbid population. So any population that's struggling with many co-occurring conditions, whether they're due to TBI or psychological distress or pain or substance use or whatever the primary issues are, that when you have a lot of co-occurring diagnoses, it helps to just treat daily function and skills and help people where they're at, get them engaged, give them a positive experience, and then move them on to whatever that next step would be in terms of psychotherapy. So that I made it through. That was all I had for today. In the future, we are testing the efficacy of StepHome in a randomized control trial, and we're on our way. We're about midway through that study, so we hope to be able to show those results again in the future. So thank you very much for letting me go over. Or I actually made it, but if our discussion goes over.
Thank you so much for the presentation. It was just fascinating. I wish we had like a whole afternoon to workshop on this. I just wanted to check with you. Has the whole program been moved virtual? And
We have.
Going to change how it's, do you like this current model? And do you think that that's sort of how post-COVID you would like to see it run?
I think that I really feel like it's allowed us to reach people in a way that additional folks that need help that may not have been able to or willing to travel to, especially a Boston-based medical center. So a lot of the veterans really don't want to travel into the city for treatment. They find it to be very triggering, very anxiety provoking. And so I do feel like being able to offer our workshops online has allowed us to reach a much wider population of veterans that need help. I think we actually have the data available now to compare the in-person to the online workshops. And we've been able to show that they're safe, that we can do it safely, and that outcomes are very similar. The one outcome that is a little bit better for in-person is therapists really like delivering the intervention better in person than online. So that intangible piece of connection that you get working with people face-to-face, I think, and I mentioned that Alex is here, that she runs the groups. I think that the group leaders really, really miss seeing the veterans in person. So in the future, we'd like to do both, because we really like to be able to reach, rural veterans and folks that don't want to come to a major medical center in a city, but we also want to be able to see the veterans again in the same room.
Thank you. And I'd like to open it up for the people that were able to stay after 3 o'clock. Does anyone have any questions? Just unmic yourself and ask away.
So that was a great presentation, Cate, Catherine. So I really enjoyed it, and I had a couple of quick questions, both with respect to, with respect to your patient population. What is the prevalence of sort of pre-existing conditions, maybe at a milder level, for example, with some of the, particularly with the emotional states? And is it the idea that the exposure to the mild TBI kind of makes that worse, or the sustaining the mild TBI makes that worse? Particularly, I guess it also applies to substance abuse. I mean, people, might be taking things recreationally, but then it kind of there's an uptick after having the TBI. So is that in any way controlled for, or do you have a sense of how that works?
I guess in terms of the intervention itself, the only thing I would say is that we do focus on everything together. So we take a very holistic approach to not trying to get folks to separate out um, any kind of current issue from the past. We kind of take it all together. But in terms of the TRACTS data, we actually empirically do know the answer to at least some of what you're thinking. And one of the slides I showed you showed the rates of post-traumatic stress disorder prior to military service. So we do see that rates of PTSD are higher among veterans prior to military service than among most civilian populations, and that having PTSD and or trauma exposure prior to military service does make your PTSD worse. So we know that. We don't have clear evidence that having PTSD prior to military service makes a TBI worse. So we haven't seen that in our data yet. It's more about the current mental function and current disorders that are driving everyday functional abilities. But I think that it's a really important question, and we feel very strongly that that's why we actually assess for all of those disorders prior to military service, that what you bring to the table prior to your military service certainly shapes how you experience deployment, service, and TBI. And that's exactly what we're trying to look at in the long run.
Yeah, because the reason I'm asking is because we're in the process of setting up a similar paradigm in our preclinical, in our animal studies, where we can induce a PTSD like phenotype in the animals. And we're we're at that point where do we do it in conjunction with the TBI, meaning have the TBI and then do the exposures to generate the PTSD phenotype, or do we do the PTSD phenotype and then come in after that with the TBI? It's a complicated question. And what we find, and this is not something this is novel to us, I mean, other people have reported, at least in the animals, is that not every animal will demonstrate. There are resilient animals and there are susceptible animals. And so sort of our starting out hypothesis was that if you take a group of animals where like 30 to 40% are going to be susceptible, the idea is that we take the resilient animals, give them a TBI, and see if we can increase the number of susceptible animals.
Wow.
So, right?
Yeah, I see what you mean. Yeah. I mean, I think that's what we find to be the most fascinating part of working with this patient population, is exactly the same thing, is the resiliency. And I think you're right that, and that's where looking at trauma exposure versus rates of meeting diagnostic criteria for PTSD can provide some answers into that. But I think that the resiliency and what makes someone resilient to brain injury as well as to emotional distress is what we're trying to figure out every day.
Right.
I was curious about like the current treatment that you were saying, and how people aren't coming on site and we're doing it remotely. I would assume that a big part of like group therapy, about collaboration, about communication, especially when there's such a sense of a loss of that community and isolation, is particularly, I'd say, risky for this population. And I was just curious if there's any strategies about addressing that.
In terms of having the loss rate now, I'm sorry.
In terms of interventions now, and in terms of the people who are in the study and doing your research with them. You said like there's really not a significant difference now when somebody posts about COVID.
So I do think that there is a big difference related to COVID in terms of people needing the support and missing the community, and that has led to us connecting with additional veterans and them being willing to take a step towards doing the group. I don't think that that there's been a significant difference in our ability to deliver the intervention online versus in person. So I'm sorry if I'm not understanding what you're asking though. Is that, are you asking, I'm sorry, I can't.
I was just thinking that there's just such a significant difference in the ability to deliver the therapeutic interventions remotely. But if you feel that they're feeling still effective, then
Yeah, I mean, we really do. We feel like they are still effective online. And that's what I meant in terms of the preliminary data that we were able to compare the in-person groups to the online groups. We have about equivalent numbers since COVID forced us online. And so far, the outcomes of the intervention are comparable with the online delivery. The only thing that showed a significant difference was that therapists didn't like it as much. So the veterans ended up doing just as well and making the same gains and attending the same number of sessions. The only other thing that was different between online and in person was that we are getting folks who are in some ways sicker, or folks who have more mental health disorders. So it seems like we're reaching a population that maybe was hesitant to come in person before. But we feel very
Can
strong.
I just jump in there too?
Yeah, I was hoping you would. I was gonna
Yeah,
pass the
I was
baton.
just gonna add that most veterans in this group, if you say group therapy, they want to run for the hills. So most veterans don't think they want or would like group therapy, and so it's often a tough sell. And even with the word workshop in there, a lot of them just get very squirrely about the word group. And I think what we found, which is really incredible during COVID, is that when they're at their home and they don't have to go into the VA, they don't have to sit in a room with their back to a door with other people they don't know, and all the PTSD triggers, it's actually much more comfortable for them. And so they feel like it actually fits their life right now. And then I think the added factor of COVID being so isolating for so many people, I feel like we've had a lot of people who are telling us like this is like a saving grace during COVID, and that they don't know what they would do without the group. That it's just so desperately needed right now. So if anything, I think we found that it's been really good to have them online. I think what Cate's getting at though is just I just personally, like, I really miss that piece of being able to connect with people in person. And then just, you throw in all the Zoom stuff that can happen when you've got different people signing in from different locations and different connection issues. And it can just make the sort of group therapy experience be challenging at times. But it's also just offered, I think, a really, really needed service right now. And the fact that we have these veterans from all over the country who normally wouldn't be able to participate, that's been pretty cool as well.
In providing
that
the
is a distinction from the civilian population too, I think, who really enjoy that sense of rehabilitation and community. So thank you for explaining that.
connection during this time is even more important.
Any other questions? I have so many, so I just want to make sure. Anybody else?
I'll have a quick question, Catherine, before you go real quick. You mentioned the outcomes related to feeling more connected with their communities and to the VA are like really cool outcomes, in my opinion, especially if you've seen that among our women veterans, which are really trying to connect them and help them feel more comfortable in VA and kind of help them connect to the next step. I was just so resonating with that process for women who experience intimate partner violence, and having this transdiagnostic workshop, for some people that will be enough. And then for people who have a diagnosis of PTSD, may be ready to do a more trauma-focused therapy. I was just resonating with lots of nice places for overlap and IPV interventions.
Yeah. I totally agree. I think that's probably what we're most proud of with the workshop is that, particularly for a group of kind of frustrated at times, the veterans feeling frustrated sometimes with the care they're getting at the VA, or frustrated with civilians and dealing with civilians after a military career. And the fact that we're able to provide this different experience and serve as a gateway to reconnect them to a feeling of team membership and community and support, and potentially change their minds about VA care, to give the VA another shot and to try something after. I think that is what we're most proud of with the group too. Obviously, we'd like to help them along the way, but getting them better connected and feeling more part of a community and more part of VA is a really important outcome.
Regina, I
Thank
see
you, Catherine.
you're on the phone. Would you like to say something? Big fan of Regina.
Yeah, I see her. I didn't see her name before. She's down there too.
Here.
Do you have any comments, Regina?
We lost her.
Can I just add something to Cate Iverson, your point there? I think anytime you have a group of people that's feeling isolated or labeled or misunderstood, or feeling like the VA is missing how these things all interconnect, I think that's one of the biggest sort of like hard to describe, but the veterans often say that they feel like this is the first place where people care about how all these things interact together. And I think that for IPV, having a place where they wouldn't feel as though it's just the IPV, or it's just the head injury, or it's just the PTSD.
Exactly.
It's sort of this like cumulative, like, okay, but it's also the sleep, and it's like chronic pain, and it's my kids, and it's like being out of work or whatever. It's that validation that it's not one thing. It's all of it intertwining, and all of it playing out differently day to day and week to week. It gets messy. And I think that they often, the veterans tell us that they really appreciate the fact that we care about how all that stuff factors into their lives. It's not just one thing.
We
So I
care
think it could be a
about
really,
to make
Yeah.
that explicit, that we get that. I think that is a really big part of it. And that's part of what I was trying to get at with that frustration with a more traditional kind of silo approach. No, I don't want to hear about your TBI because you're only here to talk about trauma, or I don't want to hear about the trauma because you're only here to talk about TBI. But really being able to put it together and say a lot of these symptoms are similar and overlapping, and let's talk about why that happens, and let's try to help you with what's happening instead of trying to specifically determine what's coming from what.
I think that Venn diagram you showed really could possibly be a teaching tool to just show the cross sections of how all those things interlap.
Mm-hmm.
One comment I wanted to make, as far as female veterans with TBI, I've talked to the Eisenhower Center and other groups trying to put together brain injury recovery programs for women. And unfortunately, as men can generally take 3 weeks off, 2 weeks off for a specific program, women are usually caregivers. So they could do 2 weekends, 6 weeks apart. But that to even suffering from a TBI, even with PTSD, you're still taking care of your mother and 3 kids and, have a job. So that this program to me is exciting because I feel like it would be more accessible to the women that haven't been necessarily reached by the residential programs.
Mm-hmm. I think so too. I think it would be great. And I think it does fit into busy lives. And, we do make efforts to have it at times and it works for veterans in the same boat. So I totally agree with that.
Is there any thought of a companion for spouses, caregivers, families to sort of wrap them in the let's work on the family around the particular person?
Yeah, Alex can probably answer even better than I can, but we specifically try very hard to do that. And I just didn't go into the details about it, but we sometimes even use Venn diagrams of PTSD, TBI, and overlapping symptoms. And Alex, tries to encourage the veterans to bring spouse, family, significant other for an individual session. So
Yep.
that's how we run it with StepHome, if you want to just.
Yeah, no, we very early on recognized that the more you can loop different parts of people's lives in, and it's not just other providers at the VA, that we've done that as well to try to provide that sort of like integrated care model that is kind of lacking right now at the VA, but in healthcare in general, to try to get the different parts of people's lives sort of on the same page. And so we offer sessions with like loved ones. It could be your spouse, it could be a parent, it could be a child, and try to provide the opportunity for us to give some of the psychoed piece that we do in the group to the actual participants and anybody that they want to have hear that message, but also just to, again, sort of validate that what they're going through is they're not the only ones going through this. And that can be really powerful for both the veteran, but also for family members to know that that we get this, we see how messy and complicated it is, but that there's a place that kind of is trying to help their loved one. I think that's been huge, and it really makes a big impact. The other thing I was just going to mention about moms right now and caregivers is that we have a lot of people in the group who are only able to participate now because we're doing it remotely, because they have a kid in the kitchen doing remote school, or they're taking care of somebody, and having to manage caregiving responsibilities. So I think it the remote option lends itself to really fitting into people's lives where they're at right now. And that's an added sort of twist of remote that feels validating to be able to offer them the remote option. It's not forcing them to get in a car and drive an hour to get to JP and park and go in an elevator and get stressed out.
Add an hour to each end of the workshop so they can
Right.
fit it in better.
Yeah, take time off from work. Yeah.
Yeah.
Well, thank you for your time today. It's just fascinating. And I was thinking back in 1991, when I was a MSW student at the VA, I helped with the first PTSD conference called the Still Hidden Soldier. And they were thinking at the time, it was the first PTSD conference they had, and they were describing PTSD as a coin where one side has substance abuse and the other side PTSD, and how did you work both sides of the coin? And I was thinking, now this is more of a Rubik's Cube, and you're shifting around, and just how far, I'm feeling old, how far the VA has come in viewing something that has been a part of war, or since war began, but that we are viewing it from so many different angles. And I think there's a great potential for healing there. So I'm very excited. I'm glad that you both were able to be here today. Cate, thanks to you. Do you want to say, 1 minute in closing?
I didn't know which Cate if you meant me or
Cate, all Cate.
Yeah. Thank you so much to Cate for inviting me to come, and both of you for inviting us. We are happy to be here and share our work and get this feedback on how we might be able to use the workshop and the approach of the workshop to help survivors of IPV. I think it's an exciting possibility for the future.
Cate too.
Thank you, Cate
you.
and Alex, for coming on and talking to us about this intervention. I see so many, I'm getting so excited, and I jotted down some notes, and I know Catherine and I were kind of texting back and forth about just how relevant the program is, and how we could listen to you talk about it all day, which we would like to do. But thank you for introducing it to us, and definitely is something I hope you all pursue. And
hopefully we will together, right?
yes, I would love to be a part of it.
Yeah.
Thank you to our Mount
Thank you.
Sinai team for helping us understand the programs that are going on and getting the links, and I'll include all those links as we send out. If you do Pink Bling Pledge, that's to the main study that she spoke about, and We're up to, I think, 550 women. It'll also, if you're a veteran and you're interested in that, you can click veterans and then it goes to the VA's PTSD brain bank. So we have all different ways to use your brain. So thank you, everybody. Again, thank you for staying over. I really appreciate it. You were so fascinated. Just could go on all day. Thank you for all the hard work you're doing. Everybody stay safe and we'll see you in a month. Take care.
Bye-bye. Thank
Bye.
you.
Thank you.
Bye.